This morning when I woke up, luckily I did not have jet lag. I thought, what am I gonna wear? And usually I don't really spend a lot of time thinking about what I'll wear. But I decided to wear this t-shirt, which is also a code. But I'm not gonna quiz people here because I do not want Carolina to chase me off the stage. But there's a code. But more importantly, I'll turn around because there's another code. And so I guess I came prepared for the fractal. But it's really, that's gonna be for Carolina to figure out what does my t-shirt say at the back. Okay, so I'm happy. Huh? Okay, great. So I'm going to talk about shortcuts in medical imaging. Here are my disclosures around just grant funding to help me with my research. I will not be selling anyone anything here. So, how many people have pressed these keys? Luckily, not many people have their laptops open, but in the last 24 hours, how many people have pressed these keys? This side is so bright, so I cannot see, but okay, I see the middle and okay, great. So, how many people undid, like clicked the shortcut for undo? Wow, really? Then you're probably not using this shortcut very well because most people don't even know Control-Z is how to undo the work for your shortcut, and so it turns out, I won't sort of belabor this, but our lives tend to be made easier with shortcuts, and we know how to undo them when they make mistakes. And AI has the same behavior, and so I'm going to talk about shortcuts, in fact, what they are, and give you some examples, and then end up talking about their impact on bias and how to overcome them. And so the problem is I'm actually very passionate about this topic, so I can speak very, 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 very fast. And so please give me a sign where if it's too quick, okay? Because I will repeat and just say the big takeaways. So, if you had these pictures, right, and what you would have is that you have a cow and a camel, and the background is what's different. So camels are found in the desert most of the time, and the cow is against a green background. Now, if our data set has mainly this type of examples, then the model does not necessarily need to learn that there's a cow or a camel. It just learns that the background is so different. And if I just learn the background, I'll probably make a good guess. And it's true, and it works because this is not overfitting because the whole data set has all these examples until it finds an unusual example, and it's like, whoa. We know that AI models don't tell us that, that they don't know, so it's still going to make a prediction, but it's really making a prediction, and this won't work because the model learns a spurious sort of correlate instead of the intention that we wanted to use to learn for our model. This is important because medical imaging are characterized by extreme class imbalance. Most data sets are normal, or the abnormality, for example, on a mammogram is just a small area. And this is why if the model just learns something else, this is important for medical imaging. And so shortcuts are a characteristic of both the data set and also the model, sort of like using discriminative learning for model training. We know today, especially with the convolutional neural networks, you give it examples and you give them some labels and the model goes and does the magic. And I know that's a very simplified approach, but we know that you're penalizing the model when it makes an error. And we know that people have sort of tried to tailor-make the loss functions, and even tailor them to classes, but ultimately, what you end up is that if you ignore the shape that you can see here, then you could say this is an elephant because of the texture, but you need to understand the shape, then maybe most of you would agree that this is a cat. And so this complexity around training is what makes it difficult with the era of shortcuts. So where are these shortcuts in medicine? So this is one actually very, very famous paper by Ziad Obermeyer, and in the US, like any place where you want to reduce patients coming back to the hospital, luckily this is one of our themes that we're analyzing here. You can try to use an algorithm that says, if you have around 58%, risk score, maybe I'm going to send you a smart weighing scale, or I'll send you a nurse to your house so that they can just help you with management of medication. You just provide them more resources because you don't want them to come back to the hospitals, patients who have many comorbidities. And so this is a commercial model already deployed to around 200 million people in the US, and it was working. And these authors, what they went back and said is, let's look at the performance for Black and white patients. And I'm going to be using Black and white patients, but I use them in a legal and social way. It's just the way you'd say, I'm Kenyan and you're from Poland, okay? We are not different really biologically, just where we were born, I hope most of you believe that, And so if you look at this score, you'll find that the white patients who are referred, defaulted into the program when they had lower number of diseases. And interestingly, the authors said, we didn't really train this model using Black or white, but they used the metric that they used was healthcare cost. But healthcare cost varies between Black and white patients, and this is because Black patients in the US tend to get healthcare from the emergency room, and they don't have primary care doctors, but white patients have primary care doctors, and they will be seen more often. And so that became a shortcut for the model to learn on. And it shows you, for example, when you use zip code, when you use these other things that characterize patients, even if you don't present them to the model can still learn about it. So earlier on today, you had this example of sepsis. And I show you this. So this color here is the alert, and then, sort of the event is the next model. And you can see, if you have a model, you don't want a model to be telling you there's sepsis when you're already making the decision you wanted to do in the first place. And in this case, for example, but this work was done by journalists. So if you really should support like traditional journalism. And most of this work was actually done with a lot of media help. And, and it says, the model was just learning that, hey, Judy is about to order an antibiotic, or I'm about to order blood culture. If I'm already ordering those type of things, then I'm thinking there's an infection. So I don't need an AI system to come and tell me, there's already, sepsis or high risk of sepsis. And the work showed that they were missing quite a lot of patients who ended up developing sepsis. And this is because the model didn't really learn what sepsis is. And now that's not a very good example, because even most experts may really debate. That's why there are many sepsis definitions. But the model learned a proxy, and the easiest proxy was, if I see an order for blood cultures or labs for, or an antibiotic diagnosis, I can guess that there's sepsis, and you're probably right, but you're not very useful. And so I'm a radiologist, so I'll show you examples in medical imaging. And so this work was done by a resident. And what they were doing was just saying, where's pneumonia? Where's the model telling us when they have pneumonia? Usually you'll have your own data set and you have an external data set. That's pretty standard now. And what they look at is the saliency maps. These are changed in color. And they find that the model's attention area was around these radiographic markers, the L's. And if you're a radiologist, then you know that these L's can vary across institutions. They can even vary across units. And so the model here was learning which patients are coming from the ICU and saying, if you're getting a chest X-ray from the ICU, you probably have pneumonia. And so it recalibrated its predictions to the ICU patient and never ever looked at the lungs, which is where the pneumonia would be diagnosed. Here is a different example for COVID. And we know that COVID models, AI models, were not helpful. Actually, it's the early diagnosis, providing PPE and the vaccinations that really changed the outcomes. I know this because I was practicing and taking care of patients around that time. And so what they do here is that they amalgamate data sets. So these data sets are called Frankenstein. And what they do is that they mix, if Michal come and say, Judy, give me chest X-rays so we can run a datathon, I can say, you know what, I have these chest X-rays here. I don't really say why I collected them. Are they really appropriate? So you just mix them, and then you're like, you know what, I have this NIH data set. it should not have COVID. It was collected in 1990, and then you bring them together. Now you have a negative and positive data set, right? And so the model works very well. You can see the AUCs are close to 0.9, but when they test them externally, the performance, has a dramatic fall. And so for the students, I would say every time the first model you build has a 0.99, that's a suggestion of an error. It's not a good model, and you should be investigating why. But the reason I show you this work is that they look again at the saliency maps and show us, okay, where is the model looking at? And again, it's looking at not the lung areas, it's just looking at those radiographic markers, and they try to also show this with generative networks. But finally, they show, they do this work where they say, change the last layer of the model and predict the sex of the patient or the projection of the chest X-ray, and the model is perfect, and it's perfect even across on external validation. The models were never provided with the patient's sex, and again, even on medical images, even if you don't provide a specific label, it's going to be learned by the model if it's encoding enough features in the data set. So, this is same work showing a shortcut learning around hip fractures. What's interesting about this data set, none of, medical data sets are not this granular. They don't consider diseases, images, patients, hospital processes. So as you walk through your datathon tomorrow, for the people who will be staying on, you could even look at the unit and start to see, can you cluster things around the units? Because those can be used as shortcuts for models. And you can see you can collect patient-level information, other non-patient-level information, for example, the timing of the study. And this visualization of embeddings has become like a favorite tool of mine. And, and you can, I'll walk you through these pictures here. If you look at this, you see sort of three big clusters. There's the green cluster here. And if you go back, now you can see the projection. Yeah, there's a mixture of projections across everything. But when you look at the patients with a fracture node, they mainly scanned on this one scanner. And so when the authors go back and now say, AI, why don't you predict the scanner manufacturer, the scanner model? The model is perfect at predicting those things. The radiologists are very agnostic to, was this a Siemens or a different manufacturer that was used to acquire images? It's like your phone. You don't really care that this was a Nokia phone or a, whatever phone it is, but these factors matter a lot for AI model performance, and not just the, the disease characteristics, but also the hospital processes. So let me show you another hospital process. So in this is a digital slide of pathology across 5 sites, A to E. And the E and F are the same slide, but they're acquired by a different camera. We are in an era of digital pathology. Very, very fantastic. I love seeing those images when I'm interpreting studies. And what these authors do, the same thing, right? So they say, could you predict, where the scanner, the date, the age of the patient, the scanner type, the preparation date, the site, right? These are nonsensical things for you to do. But the model is very, very good at telling you what hospital those slides came from. And it's also very good at telling you what the scanner type is. And what is even more surprising, this is not very good, but it's surprising that it's getting a sense of even the dates, like the ranges of the timing when the scanners were acquired, right? These are not things that humans are good at, or even the scanner preparation date, where you see there's still some signal, right? There should be anything that is encoding this type of information on the slides. And so we start to find that in pathology, they call this batch effects, and we start to find like even the slices of cutting, the pathology slides is so important for the deep learning model, and affects how, the slice thickness starts to affect how the nuclear, and you're trying to build a mitotic count, the slice thickness affects this. And even some people are now moving to robotics to cut, to aim for that precision. But if you're going to use the data sets that we've acquired for years, they are human. They have human artifacts on them. And so this is one of the bigger challenges. So in radiology, and I don't know why in pathology that happened, but in radiology we know, I've kept saying, I can show you the radiographic markers. That's what the model is looking at. In this example, these authors try to predict the hospital type, and it does a good job at doing that. And when they look, and initially I was like, oh, it's just going to be looking at the radiographic marker, right? But no, because it turns out that for these new radiographs, every hospital puts in a metal rod so that the patient's knees could be straight, and they can also be used for measurement. And that metal rod was distinct enough in specific hospitals to say, oh, I know that this is this hospital versus another hospital. And I showed this example to remind me to tell you that just because you have one shortcut, it's not one shortcut in the data set, there are multiple. And when you remove one, the model just finds another one, which is why this remains a big problem. Now, segmentation is the gold standard for medical imaging when you draw things. But when you have things like a caliper, which is a ruler on this ultrasound, the model does a very good job. It's centered its predictions. But when you start to remove the shortcut, the model starts to struggle about figuring out where things are. It's even worse because most of our public data sets, these are 4 data sets used for pathology, the pathology image tends to be dead center in the field, right? And it's just like if I was to take a picture of the room, I'd probably move to the center and take, things very central, so that positioning. And that's what happens with our acquisitions. And so when these authors try to change the location of this melanoma, they show that anything that is far from the center, the performance starts to drop down. So it's not really learning the melanoma. It just learns if your center and all the other things are away, the center one is the malignancy. And so it's really not learning anything to do with AI. Now, so far, I've been showing examples about convolutional neural networks, but now we're in the foundation models, right? These models are trained on big data sets. We are told that they can see, they can see text, they can see the images. So is this true? This is amazing work done. And so they look at these markers. This is not unusual in medicine. If you have to go to a tumor board, we saw an example of sort of like acceleration. You don't want to be fumbling and all the experts are there. So you can draw things on the slide so that you show up and, things are ready. And, so they show this model and, they try to add artificially sort of like misleading information. So one has no label, one has the true label, and one has the false label. And you can see when there's no misleading label, the model is completely cannot even function. When it's a true label, it's like perfect. And then when there's no label, it starts to randomly guess in the middle. And then they say, ignore the material that's misleading you, ignore the text, right? And if we look in our world, that's what people are saying, that these vision language models can do this. They find that the model still defaults on the text. So you cannot really direct the attention of the model. And this is increasingly clear to me that language and images combined for the doctor is not really helpful. And unfortunately, the language models are getting better, but the image encoders are still not very good. So 3 years ago, we published this work where you could tell the race of the patient from their chest X-ray with amazing ability. Luckily, this work has stood the test of time. We couldn't figure out what shortcut or confounder it is. And a lot of other people have come back and said, okay, here are some of the things that you can do. I summarized them as this, that if you had my chest X-ray, you could say I'm Kenyan or I'm black, and I put that to just show you the ridiculousness of classifying people by race. Then you could say my chest X-ray age is aging faster. We know that you can get a sense of aging as radiologists. This is something that you can see on the images. And then I live in a deprived area. I'm going to spend a lot of money the next year, and I have these diseases. You can just tell that from a chest X-ray without anything else. And we don't know why, and we don't know when the models use this. And so some of the work that we've tried to do is to say, can radiologists do the same? The radiologists cannot tell, we can tell sex, by artifact of breast tissue on chest X-rays, but you cannot tell race from images. And the models seem to encode these characteristics variably across different disease predictions. Like here, it's pleural effusion and cardiomediastinum and large cardiomediastinum here. But it turns out that when the models encode sex and race, and this is bringing the intersectionality of our identities, we're not just one person. We're usually one person, you're Judy and you're someone else, and even across time, then the models really tend to have the most bias. So every time, when we publish that paper, everyone would say, okay, so what? If you can look at me and say, yeah, Judy's black, so what? We find that the models can encode this, but it turns out even the vision language models that are trained on more data sets, and you'd think they're more robust, they can encode a lot of things. And here is one where they show disparities, right? So this is like a disparity of 1, like pretty much terrible. This is 0.25, like 25% on sex and age. And they look at all these diseases, and And I'm not trying to bother your eyes, but I just want to show you some top diseases like a tracheostomy tube, dual chamber device, vascular redistribution. Those things tend to happen on older patients. And the data sets that we have, they'll be found on older patients because a 20-year-old, yes, if they had a congenital heart disease, they would have a pacemaker. But most 20-year-olds are not walking around with pacemakers. So the model learns to get these features and then uses it for their prediction. It's not a bad thing, but it turns out that age is probably one of the biggest confounders for medical, AI use cases because the diseases are distributed differently. And this just tells me that AI is a very, very, very good feature extractor. And I'll show you what could be the potential for that. And so, this is commercial models. This is a model even approved in Europe. What they do, the testing, they just change the right and left knee, usually because most of us are right hand. Your right knee is also your dominant, so you put most weight, so it wears out faster. So if you change the knee in your test set, they find that the left knee becomes like higher graded more than the right knee. And this is just showing that the model was able to figure out that the right knees tend to be more sicker than the left knee and use that in its prediction. And then, so how we've been using this type of subgroups, if you can figure out the characteristics, is for real-world evaluation of models. So here's a model that this paper is just about to be published. It's used for breast cancer detection on digital tomosynthesis. And what we looked at is these various classes. Instead of saying, is there breast cancer or no breast cancer? And, it's just to say, look, tell me what happens when it's invasive cancer, non-invasive cancer. Non-invasive cancer is even better because non-invasive cancer, it tells me that, this is cancer that if I detect it early, I have a chance to actually change the patient outcome because it's early stage cancer, I can treat and give a cure. And for all these models, the deterministic ones, you have to set a threshold for your performance. And you find that the model misses 45% of non-invasive early cancers. And it's good at other things, but then you start to wonder, why is this model missing this? And it turns out it's because most of the early DCIS tend to be calcifications, and those are very, very fine. And so it's how you pre-process your data. If you are sampling the whole image and putting it as 256 by 256, your calcifications are gone. And this is why we cannot really still continue to treat medical images as cats and dogs. Those are not going to translate when it comes to the real world. So, I'm still saying, look, we are using the shortcuts to figure out what are new clusters of places that we couldn't have studied before, and then looking at how the model performs. And it's an amazing way to do it, to figure out, because there's never going to be a model that works 100%. We just have to deploy them, and it's probably multiple models, and then say, don't be careful when you use the model for this subset or not. And so, here is another example. This is looking at another commercial model for intracranial hemorrhage, but these models are already being used in Europe and the US. If you have green, the model is doing well. If you have sort of this orange, the model is not doing well. So by size, you can see that there are small areas of hemorrhage, the model is not doing well. Or if you have an outpatient and you have single clusters. So this is busy just to show you all the possible dimensions you could look at medical images. And so, and this is really my thing, showing you why it's so complex. And again, like Steve said, we're trying to figure out how to do implementation science. So this model, there's just this one finding I found consistent. The model had the worst performance for Black patients as one group, and also patients who are under 40 years. So it turns out that our Black patients at Emory get healthcare in the outpatient and emergency room. So, but we already knew the model had a 10% performance drop. Then the age cluster, so we started to look at characteristics. So our young patients are Black and our older patients are white. And so that makes sense why it wasn't working well for under 40s and reminding us about intersectionality. And then the Black patients had subacute hemorrhage, while white patients had acute hemorrhage. What does this mean? The white patients tended to be older, they're having surgery, so they have fresh blood. Fresh blood is easy to detect by AI, but Black patients were younger, and we don't know why, by the way, why the patients, are they coming to the hospital and being sent away, or are they staying at home? Because when you're young, you'll be like, it's just a headache, like it can't be anything wrong, right? So there could be a difference an artifact of a delay in access. Patients are staying at home more because they don't think they're that sick, or they're coming in and they're being ignored because who is thinking that, why would I be ordering all these tests when you're a young patient? So we don't know those artifacts. So it could represent a delay in access. And then when we look at our Black patients, they had more single compartments. Well, if someone has cut your brain, then you have blood in more than one compartment. And so this was the other artifact. And so, it could be something to do with mechanism that young Black patients tend to have hypertension, which is the cause of the hemorrhage. And so that presents different. And so it's so difficult for you to expect any regulatory agency to go through this systematic way for you to be able to say, be careful when you're looking at these patients who are outpatients, but that's where you need the algorithm the most. This is where the uncertainty is. And if we don't start to look at where AI fails, and we cannot anticipate all the classes, but this is where we can use shortcuts in a meaningful way, we're not going to help patients, and we're not going to help the radiologists who are reading this. So, not because I knew that the theme was going to be AI needs you, but I still really want to speak especially to the clinicians in the room, because most of the time we're so intimidated when people come and say all these mathematical things. And we really have to bring these teams together. And this is why I love datathons, because if we're not asking the right questions, you're busy. It takes 3 hours today. I don't have a lot of compute to train a model, but I can tell you none of these models are going to be helpful unless we start to think, what does it take to bring them to the bedside, to bring them to the patient? And and you have to think about how to organize. And I have to say, not because Roche is asked me to say this, I'm so impressed that a company can believe in this type of vision. I find it very, very difficult, and it's mainly you're mainly like an academician who's trying to say this is how we should do this, or your society is trying to say this. So thank you. And also the hospital to believe in this and say, let's just try our first data set. It's gonna be messy, but there'll be so many lessons learned. And this is how we again bring this AI close to the bedside. Today, what we know is that AI is an excellent feature extractor of the data sets that you have it on. And that means we will need replication studies. We will need domain experts. We need to test. I've moved away from saying, let's have bigger, better training data sets. It's very hard to do those. But if we can start to bring better testing data sets, even if the only task for the people who will be staying for the datathon tomorrow that you do is pick a public model and test it, that's already a big, big win. And then, again, reminding us of the human factors and how to bring explainability and more sense to the people who are using this model. So thank you. I'm looking forward to the datathon. This is a picture from this year, just to help Carolina. It just means equality is better than division for the theme. That's the code on our T-shirts. But behind is that this last few years in the US, you have to be very careful about saying bias and all these words, and even studying health equity. And so the T-shirt picture at the back, which I did not put on the slide, it just shows that we are kicking these words. They're banned words. We're kicking them to the garbage cans. But if you reorganize them, you'll see that bias is everywhere, and especially in AI. So thank you very much. And here's my contact information.